A lot of the advances that we've made in surgery aren't necessarily just because of the surgeons themselves. It's because of the better ways we have of keeping the patient out of pain and still when we do the surgery. Stay with us as we talk about new trends in anesthesia.
Kentucky Health addresses the healthcare concerns of all residents of Kentucky and surrounding states. It was created by Dr. Wayne Tuckson, a colorectal surgeon practicing in Louisville. Here is your host, Dr. Wayne Tuckson.
Hi, and welcome to another segment of Kentucky Health. Today we want to talk about anesthesia, which is the absence of pain in this case, or absence of sensation. This is the thing that makes it possible for me as a surgeon and for all the other surgeons out there to do the things that we can try to do for patients to make them better. There are different ways of going about this. Some things are safe, some things may be a little risky, and there's a lot that's going on and that most of us really don't have a good idea. And I have to tell you, me as a surgeon, I don't always know what's going on the other side of that curtain when that anesthesiologist is putting the patient to sleep. With us today, though, we have Dr. Laura Clark, who is a professor in the Department of Anesthesiology at the University of Louisville School of Medicine and director of the residency program, as well as director of the Regional Anesthesia and Acute Pain Program. Dr. Clark, thank you for being with us today.
Pleasure to be here.
Now, Laura, I keep thinking, we've had the pleasure of working together. I've had the great pleasure of working with you. But when we think about anesthesia, what is it that's actually going on?
That's an interesting question, and I wish I could have a complete, total answer for everybody. But oddly enough, the gas anesthesia that you have, we really do not know how it works.
Really?
For the gas anesthesia. But we know that when we deliver that and when we take it off, you enter a state of hypnosis, not like I can give you a suggestion, but your brain is put to a lesser state of awareness than you would be, obviously. So you don't know what's going on. You will still feel pain, but you won't be aware of it.
I always thought that when looking at what you guys do, you're lowering the level of consciousness for a person, and then you're also, I guess, paralyzing them so that they're not moving around. And at the end of the procedure, you reverse the paralysis, and then you raise the level of consciousness.
That's right. We don't paralyze everyone, though. It depends on the operation itself. But for general operations on the abdomen or something where the surgeon would need the patient to be very still, we do paralyze, but not every case.
Now, anesthesia is a specialist. You do special training in order to do what it is that you do. Is that correct?
We go to medical school, and then we do 4 to 5 years of extra training on top of that.
So it's a very specialized area.
Right.
Of people who are doing this. Now, within anesthesia, are there different kinds of specialties that one may go into or one may do?
Yeah, they specialize just like any other doctor does. Like a cardiologist specializes in the heart. There's cardiac anesthesia. There's anesthesia just for kids, pediatric anesthesia. There's anesthesia that is neurosurgery related. And one of the ones that I do is regional anesthesia. And that's where we concentrate on the delivery of local anesthetics for pain relief that's in conjunction with surgery or even going into the postoperative period.
Is that one of the newer things, the regional anesthesia?
Yes, it's only really come about over the past 10 years that it's boomed and really started. We've been giving a little bit of anesthesia, regional anesthesia, say for an arm surgery with what's called an axillary block, where the local anesthesia is put up in your armpit for a long time. But now we have better equipment, and we're able to put local anesthetic in almost every area of the body to help with pain relief and also to help lessen the amount of anesthesia you might need.
Well, we're going to talk more about that in a little bit, but I wonder if you could tell me, I sometimes see patients, and I imagine, well, I know before I operate on them, I like to see them, evaluate them so we can sit down and say, okay, here's what we're going to do, and talk about the risk associated with that surgery. Do you like to see your patients before you get to the operating room?
You know, I had surgery 2 times this past year, and it really brings home the fact that as patients, you need to speak to your anesthesiologist. You don't take that for granted. That is a big part of the surgery. And so you want to talk to them. You want them to know everything about you, so the anesthesia that they give you is just for you. It may not be for this person over here or this. It may be different for the conditions that you have. Maybe you're diabetic, maybe you have high blood pressure, maybe you've had surgery in the past and you've had issues. Maybe you've thrown up for days after your last surgery. Maybe you're not quite in the best shape. You know, maybe that needs to be looked at. So the anesthesiologist will look and see, because you might have just seen a surgeon or this or that, and the anesthesiologist will look and see, well, maybe you need to see this cardiologist before this stressful operation. And they'll kind of bring everything all onto one page and get all the players together, and plus discuss with you your questions, plan, and what your preferences are.
What about some of the things you may look at that may make a person more risky for different types of anesthesia? For instance, obesity or long history of cigarette smoking. Are these things that you have to take into account?
Certainly. Especially obesity now. The obesity epidemic is not only outside the OR. We have that in the OR as well. And elderly. The elderly population by 2010 is going to probably increase by at least 2% per year, they're saying. So in the next 10 to 15 years, population over 70 is going to greatly increase. Everybody knows that after 70, things don't work as well as they do as you're younger. Your airway. A lot of people don't realize that we have to do things to breathe for you while you're asleep if it's a total anesthetic. So we may put some devices down with the reason for the sore throat to actually breathe for you. We may have a machine breathing for you while you're asleep in most cases.
What about, a lot of patients are taking medications, different kinds of medications. There's prescribed, and then there's the herbal medications. Does that present a unique challenge for you?
Herbal medications are this black box that nobody knows exactly all the things that happen with herbals, but we like to know what you're taking. We know there are a few things that we want you to not take that may increase bleeding or that may increase the effect of anesthesia on you. So we always ask patients about all their medications. One of the reasons to talk beforehand is to say, well, this is not something you want to take the morning of surgery. This you do want to take the morning of the surgery, and help to organize what is going to be beneficial and what's not for the surgery itself.
What are some of the top concerns that patients bring to you or that you discuss with them about anesthesia? Historically,
I can break those down into 2. One of those is, am I going to be awake? And they hear all these horror stories. There was even a movie, this and that. That's one of the things that's always a concern. And the other is, am I going to have pain? And how much pain am I going to have after the operation? And those are the 2 main concerns that most people have.
Now, I must admit, I have had a patient who was awake during a procedure, but if I think back about the total number of procedures, that's a relatively rare occurrence though, isn't it?
It's extremely rare. It's very rare, and one can never guarantee, but we do have some monitoring devices that most places in Louisville use. And it's a little strip that you put on your forehead, and it will tell you, and it'll look at your EEG brain waves during anesthesia, so we can get a relative guide of how deep or how light you are. Nothing takes away the total risk, although, like, you're correct, the risk is totally small, but this decreases it by 80% to use it.
What about the patient who wakes up having pain? What do you do? What do you tell the patient about that?
You know, what I try to do is I try to allay the anxiety before they go to sleep, and I try to make sure that their pain is controlled before they go to sleep. And then I had a plan for what we're going to do afterwards. For years and years and years, the only thing we've had is morphine. And then there was the development of the PCA pump, and everybody knows the button that you press and that type of thing. And that was pretty much all the strides in pain. All these other developments were being made all over the place, but pain hasn't really come along until just recently with regional anesthesia. We've been able to target nerves, or with epidurals, just like with childbirth, we're now using that for surgery itself. And in trauma victims, with with rib fractures. Rib fractures, if you get over 4 rib fractures, you have a 30% chance of getting pneumonia, even if you're young.
Because you can't breathe?
Because you don't breathe well. And then you don't move and you're splinting, and so I always try to explain patients it's like a sack of grapes. And if you have a sack of grapes in your refrigerator, what happens to those grapes on the bottom? And this is the same reason that you need to move after surgery. Those grapes on the bottom get all soupy and yucky and all that kind of thing. That's like your alveoli in your lungs. If you don't expand that, they get soupy, which is a great breeding ground for pneumonia. And so that's why anything that we can do to relieve a person's pain so they can get up and move, and they can move from side to side and they can breathe with good pain relief is going to decrease their time in the hospital. It's going to decrease complications that they may have, like pneumonia, and it's going to speed their recovery. It also decreases chronic pain. You'd be surprised the number of patients that 6 months down the road still have some pain or this or that. If they have good pain relief during their hospital stay, much less incidence of pain down the road several months to a year after their surgery.
What are some of the things that we can do to try to minimize the pain that the patient has following that surgery then?
I think one of the things is to be educated. A lot of the surgeons a lot of times don't even tell, and that's one of the things I like for your audience to know, that there are things that can be done to decrease your total amount of pain so you don't have to depend so much on morphine, because the morphine or the narcotics that you use causes nausea and vomiting. Bowel function doesn't work as well. You're groggy. You're not able to participate in getting yourself back on your feet again. So one of those good things is neuraxial blocks or regional blocks. And that sounds like big words. Nobody knows what they mean, but you know what an IV is. And an IV, you put an IV into your vein and you drip the water in there. Well, think of that little same type of catheter next to your nerve. And we drip a little, instead of water, local anesthetic. So that can go on for days with a little catheter in there, or it can be a single shot block, you know, where it just will go for about 10 or 12 hours if it's a surgery that's not a lot of pain. But any extremity, we can do that too. And then if it's an abdominal, we can do an epidural for abdominal surgery.
Well, hold on, because I want to first talk about what are the different types of anesthesia that are available. I know we've touched on it a little bit, but let's start. What is general anesthesia? Now, I must admit, I think the big question is people always say, am I going to be put to sleep? And I assume that that's what general anesthesia is.
Yeah, general anesthesia is like the big hammer. We're going to knock you totally out. We're going to take over your breathing. We're going to make you totally asleep. Paralysis may or may not, with 2 forms of drugs. One may be gas that people are familiar with, and usually that is after you're initially put to sleep. Very few people now are actually put to sleep with a gas and mask. It's more through an IV, and then maybe during the anesthesia, for during the surgery, you have gas as a maintenance. The other one is the one that just got popularized by Michael Jackson, and that's the white stuff, and that's propofol. So propofol is the most common way we put people to sleep intravenously, but you can also use that for the whole surgery itself and not have any gas at all.
What about the need to be intubated? How do you make that determination?
That depends on whether we need to paralyze you, and it also depends on the site of surgery. If it's a peripheral surgery, say legs or arms, you can most likely breathe for yourself, depending on all those other factors of how sick you are, how old you are. But most times we can let you breathe for yourself with that kind of surgery. But where you have to have paralysis, abdominal surgery, big surgery here, we'll usually breathe for we'll breathe for you during the surgery.
There's something called conscious sedation. I know this used to be used a lot when doing colonoscopies, perhaps even some bronchoscopies. What are we talking about here?
Well, that's where we just give you a combination of drugs so that you're in I call it a la-la land. And you don't really care. We give you some pain relief, but you're breathing for yourself and you're conscious. You're able to respond to me. And that's one of the dangers of conscious sedation if it slips too deep into a general anesthetic, which is actually not meant to be.
So is that something that's done by any physician, or again, it should be someone one of the anesthesiology people?
You're pretty much credentialed. There are different physicians that are credentialed to do conscious sedation.
And this is a fairly safe, easy thing to do for most people?
Yeah.
Now, let's go to what I think is one of the things I know when I had the pleasure of working with you at the University of Louisville that I found just fascinating is this thing about regional blocks. Now, you've touched on it before about different regions of the body. You're just isolating that out. But so how do you approach this, and what is the philosophy behind this type of anesthesia?
Well, the philosophy behind it is that if we give you regional anesthesia that's total, we don't even have to put you asleep. And that's one of the things that I try to tell patients when patients go, oh, I don't want to know anything. We have drugs, so you won't know anything. But you'll still be breathing for yourself. We won't put a tube down you. But we can also do a combination of both, decreasing the side effects of general anesthesia and using regional anesthesia. So some examples. Some examples are, say, for a knee surgery. Instead of putting you totally to sleep for that, we can put a spinal in, and that will numb you from there down, or we can put an epidural in that will numb you all on both sides, or we can just numb that one leg. And so we can take the nerve that supplies the top part of the leg, and we can take the nerve that supplies the back part of the leg. We can put a block on each side of that and a catheter, and you can have that pain relief during your surgery, which may or may not have an overlay of hypnosis or general anesthesia. We can leave that catheter in, and you can have pain relief for 2 to 3 days.
Now,
and the pain relief is not total anesthesia. We can tweak it now so that you have sensory and you have the muscles. So the muscles will allow you to walk and move. We can make it so we just target those sensory nerves, which are smaller than the nerves that supply the muscles. So you can actually walk after your total knee or after your total hip, but you'll have less or no pain. And I hate to ever say no, because we always augment it with whatever, but it will be much less pain than you would have if it was just with narcotics. I try to explain to people that we've at least determined now that pain is not caused by just one thing. And if you think of a farmhouse and you think of different gates leading out into the main barnyard, you know, you got the cows coming in here and the goats coming in here and the chickens coming in here. Well, what we're doing with the morphine is we're only stopping the cows from coming into here. So if we give some other medicines by mouth along with regional anesthesia, we can block all those gates. And I can load you with tons of morphine or narcotic, it's never going to touch those gates. So now we're doing a more comprehensive pain relief, and we're finding that the term of it is called multimodal analgesia. But when we combine all these things together, it greatly decreases the side effects of all of them and greatly increases the amount of pain. And it's a whole new ballgame for surgeons and patients alike. We all have to be educated that we're able to do better now than we did before. And it's not just being nice. We've actually shown that giving someone pain relief is actually therapeutic. It actually, and one description of that is the stress that your body takes. If I whack you over and you have this big surgery, all your forces are trying to make yourself better. It's very hard on your body. So if I make it easier that you also don't have to fight pain, you actually do better. You recover better. You're able to fight off infection and things better. It's just a general better concept for you to actually recover.
I like the idea. I can hear patients saying, you are not going to stick a needle in my back.
Right.
You're not going to pith me.
Yeah.
Now, this is a safe procedure, I presume.
Yes.
What is it that you're actually doing when you're doing a spinal block compared to the epidural? What is the actual technique and what is it you're trying to do?
That's a matter of depth. So spinal block, we can't do like we do with the peripheral nerves that I was telling you about. That's all anesthesia.
Okay.
We can put some narcotic in there and give you some pain relief after that, but that's in the spinal space where the fluid is, not where the nerves are.
Okay.
And that will give you total anesthesia. The epidural is
for that area.
Below
the level. Okay.
Below. An epidural stops right before entering that fluid space, and we let that medicine just diffuse through. So it comes on slower, and it usually is with a catheter. We thread a catheter into that space so we can give you the amount of medicine you need over time, and it can last for longer than a spinal. So those are the central regional anesthesia, and then the others are the peripheral. And with peripheral now, we find those spaces with, say, a nerve stimulator or an ultrasound machine, where we'll actually look, and we can look and see your nerves, and we'll numb your skin up, put a little needle through there, and there's no easy way to get through the skin, but it's not any really different pain-wise than an IV.
I've always thought that there were complications associated with general anesthesia because of the need for intubation. Are there fewer complications when you do regional and or spinal anesthesia?
That's a gray area, and it's very subjective. Because when I have to have a tube placed down your throat, it's a huge stressor on the body. And it depends on your cardiac status, your lung status. If you have COPD, obviously you don't want to do that if you can and avoid it. But the complications related to each are very subjective in that you can't, with studies, scientific studies, because they only look at death, basically. They don't really look at some of these intangibles that you can see. But if it was my mother having surgery and I could do it where I wouldn't have to have that down her throat, I would say do that. In fact, my mother had a fractured ankle. She has bad COPD, 86 years old. Why do I want to put her to sleep for that when I don't have to?
What other complications should we be aware of when we're talking about regional anesthesia or even general anesthesia, but particularly regional? Anything?
Well, with regional, anytime you get around a nerve, there's always a chance for nerve damage, but it's very, very low, just like with general anesthesia. You know, anytime you have general anesthesia, there's a risk of anything from chipping a tooth to dying. There's always a risk with everything. And I usually explain to patients there's a chance of infection. We're going through your skin, just like with surgery. There's a chance of any kind of nerve damage, just like with surgery. But it's really, really quite low.
What is in your experience, this may not be a fair question to ask you, but we'll ask it anyway. What is the limiting factor for many anesthesiologists not to talk about doing regional anesthesia for patients?
I think that has to do with education of the public and education of surgeons. Because the time constraints to place a block, it takes a little more time to place this block. And with surgery schedules, surgery time, getting patients ready, and a different anesthesiologist learning how to do regional anesthesia. All of these weren't taught, all these blocks, when they were in practice. We're now teaching all of our residents, and a lot of the anesthesiologists in the area know regional anesthesia. But that is a drawback. So having the time to place it in the schedule, and that's why I think that over, not my lifespan of work, because I've been working a long time, but my residents that I'm teaching now, I think we're going to see that these aspects of regional anesthesia are important. And we need to allow time for them to occur, because it should be the patient and the patient's pain that comes first. And to allow anesthesiologists the time to do that, and not just, well, let's just go on because we don't have time. Because sometimes now, first cases, we'll have to do the blocks after the case is over, which is not ideal, but it's better than nothing, because we don't have the time in the mornings to get them in. But I think, you know, with education and people, surgeons and public and everyone realizing that it really does have advantages to the patient's whole outcome and whole hospital stay, I think that's going to change.
You think so? See it happen. Well, I can tell you, again, Dr. Clark, again, I have a bias because I've worked with you in the past, and I know a lot of patients came in saying, you know, there's no way you're going to put a needle in my back. And at the end of the procedure, when the patient is not having any pain, the patient is comfortable and they're able to get up and walk, they felt good and they did not regret it. Doing regional anesthesia, I've seen patients have surgery on their arms, legs, etc., and they have done quite well. I think this is one of the most exciting areas in anesthesia, and it's exciting for even me as a surgeon because the patient's up and the patient's happier, therefore they're happier about us. If you have questions on this topic or any other, please feel free to contact us at KentuckyHealth@insightbb.com, or feel free to try to contact Dr. Clark or your other healthcare providers or anyone at the University of Louisville Anesthesia Department. Thank you very much for being with us. Hope you get a lot of calls about people wanting to talk about regional anesthesia.
I love
Laura,
it.
thanks for being with us today.
Thank you.